All right, perfect. Well, the other thing I always say at these talks is that I'm super grateful to be able to do this in this fashion, So I think most doctors probably want to educate their patients, at least in a primary care role. And when you do that, basically it's a direct loss of income in most models. As an educator in a university program, I was paid a salary to educate, not necessarily my patients as much as the other residents and doctors. But that really showed me that, that was a really important part of just healthcare and being healthy and maybe getting well even. And something I think that patients really want. So that's probably the biggest intention of my YouTube channel, really, is to drive forth the health of my direct community, really, but anyone else who wants to listen. So thank you guys for making that possible. Everyone here that's my member, or even if you're not, just being here and giving me your attention, I really appreciate it. So today's talk is going to be about lab interpretation, which is a super important topic. As we'll talk about, labs are not everything in health, but they are really important data points that can really help us guide our health, tell us about illness, obviously lead to certain diagnoses, lead to maybe early diagnosis, we'll see, of things that maybe could then be preventable. And then there's many things that maybe labs can't tell us. So we'll kind of, again, understand the connection to health, not just that they're the end-all be-all. Quick disclaimer, this is really meant for general information purposes. I may be some people's watching doctor, and we may have a doctor-patient relationship. This video does not constitute a doctor-patient relationship. It's really just for general information purposes. This does not, again, replace a discussion with your doctor, so this is not a replacement for you to then go and talk to your doctor about your labs, okay? And then with this, I do actually have a conflict of interest, and that's only that I contract with LabCorp for my labs directly. So if I talk about some pricing and some things in my current model, then you know that I'm signed up with a contract with LabCorp, so just being open about that. What are we trying to accomplish today? Hopefully we'll understand what labs can tell us, and like I said, maybe what they can't. We'll have a brief overview of biostatistics and lab technologies. I think that's just important to know how labs are processed, because that's, again, I just feel it's important to have that understanding when you're looking at that data. Where did that data come from? What is the quality of that data? Let's say that's what that tells us. And so again, what can they tell us and not tell us? Process in accurate diagnosis, right? So how do we make a diagnosis? And so that's that connection to health, right? So how do the labs then inform us about that diagnosis is kind of what I'm getting at here. And then we're going to go through a bunch of commonly ordered labs. So I have some examples on here, and we'll just go through what those mean, basically. So what are they? They're, again, they're data points. So you get labs, whether they're blood, urine, one point in time, surgical. There's all different ways that you collect something from the body, and then you're going to derive a piece of data from that. So obviously, depending on what that specific lab is, that is going to vary on what that is. So in the blood, we might measure the concentration of certain electrolytes, certain metabolites, right, which because based on our knowledge of biology, physiology, we know that that should fall into certain parameters. That's been done over, again, decades of normative testing as well. So millions of data points over millions of people to say, hey, the human existence, these are kind of the numbers that are possible. And then we set kind of these limits that we know are kind of within certain statistical bounds. And that's what's really called normal, right? So you have to understand that that's what that data point is, right? It's a singular data point of a concentration of some sort of specific molecule, or it's a measurement of a certain, let's say, cell, or a pathologist or radiologist's opinion. We're not talking about radiology really here, but in the lab department, there are some subjective measures like pathology, which again, does have kind of human being or computers nowadays a lot reading out certain statistics on things or certain characteristics, let's say, of cells and things of that nature. So that's what I mean by population curves. So Again, is that clear what I mean there a little bit? Does everyone want me to dive into that a little bit more? Okay. So again, so that when someone sees high, low, I kind of tell them, hey, it's high or low is not you're dead or doom or anything like that, to be kind of extreme about it. But again, we have to just have maybe a reasonable explanation, or it just puts you at an extreme of let's say a large population curve. So maybe you live there, and maybe you live there for a good reason, and so that's again, as long as we have a clinical reason, or we know that that's yeah, we know that we're doing some tree work, so I think that's what's going on. Yeah. So so that's what I mean by that bullet point. Concentration, density counts, right? So again, when we get into cholesterol, when we get into the electrolytes of the blood, you have to understand that, okay, your sodium, does that mean I need to eat more sodium, right? Or potassium, does that mean I need to eat more potassium? That's not necessarily the connection between those labs. These are the concentrations of these electrolytes in your blood, right? And that is controlled by a certain organ, and it informs us about the sort of health of that organ and sort of an intricate balance, right? These are static data points telling us about really complex evolving systems. And so just again, that kind of gives you sort of an idea of what some of the limitations are. Again, we can maybe compare this even to, let's say, the weather, okay, like another very complex system. If you guys have lived here recently, you could see a cloud over there, see a cloud over there. There, all of a sudden, there's lightning. Maybe it's going to rain, and then it doesn't. So it's a complex evolving system, right? So hopefully our bodies aren't quite that chaotic, and we can achieve some equilibrium in this system. But again, we have to understand that we're catching a data point somewhere in sometimes a very chaotic system, right? So we want to get some data points sort of over time, understand some trends that can really help the accuracy of our understanding of certain things. People want to sometimes, I think it's probably mostly driven by the hesitation of being afraid of needles, or some people have like cost or other considerations, but repeating labs sometimes is like, oh, why would I just had this. And it's like, this is one big reason, right, is it really helps you understand, especially if you made a big change, then you want to see what that does over a reasonable time period.
Is the LabCorp the one across the street?
Well, that's just a draw station, right? So LabCorp is a huge lab vendor that, really, right. So it gets, I think most of the labs drawn here are processed in Denver. Mm-hmm.
Well, I must say that the ladies who work up there, the lab,
right, and that has, I mean, they are employed by LabCorp, and but that is definitely like a draw station.
Yeah.
So yeah.
But
anyway,
for those
yeah.
who are afraid of needles, most of the time she's done on it.
Right.
So I thought that.
Everyone has different opinions there. So, and there are some involuntary reflexes involved there too. So, other kind of labs that you can get. So there are, like, you can test your genes. We'll talk a little bit about how that's still limited in what it can tell you, right? So we have all sorts of genetic tests, some that are cancer profiles, some that tell you about dementia, some that tell you about all sorts of different characteristics. If you guys have heard of these other kind of third-party self-tests, 23andMe, you can get your earwax type and your hair type and things like that, as if you didn't already know. Again, these things are linked, let's say, to genes and have drive you to certain tendencies. But what we're discovering about genetics, right, is that there's something called epigenetics, and even some maybe things other more complex than that drive the expression of certain genes. And we see that genes are not the whole story, right? And so this kind of nature versus nurture, really, we're finding that it's a bit of both, right, in most cases. Yes, and there's some things, again, there are some exceptions to these things. I'm talking what I might say is this let's say 80 to 90% of things might fit into the rule I just said, right? And then of course there's many things that are completely genetically inherited or not. So PCR refers to another genetic amplification. We'll talk a little bit about kind of some of the limitations of that, right? Because it's finding a certain code and amplifying it. That doesn't necessarily mean there's living tissue there, living bacteria, we'll say, for example. Antibodies, these are, again, kind of basically your body, your immune system, the way your immune system really works is to create a protein to sort of neutralize something or recognize something that it deems an invader, right? So if that's a foreign pathogen, then that's great. Then you have immunity to all sorts of things we all have immunity to. If that's, a food product, then you call that an allergy, or, an inhaled, kind of pollen, then again, so that's how that kind of works. But these antibodies can also now be created through different scientific methods and can also be detected, right? So as labs, we can actually use lab techniques to then say, hey, you have antibodies to this. So this might be like titers to certain viruses or bacteria, or again, other kinds of testing there. And then I sort of hit on tissue samples already, right? So that's just whether that's cancer screening, just something like a pap smear, you're taking cells from the cervix. That's what that procedure is actually about. And then, let's say there's a concern, you have a skin cancer. I might do something like a shave biopsy in my clinic, right? And so that takes a piece of that skin and sends it to a pathologist and sort of tells us about maybe skin cancer. So lots of different examples of how we can take tissue samples. So kind of diving into any questions about anything there? All right, great. So what did they tell us and what is not, what not? So I really, I just want to pause on that first bullet point really for a minute. Clinical picture is so important, and what a patient feels and experiences, and sort of just a step back of kind of what's happening, in the full picture of everything. What situation is the patient in, maybe even more socioeconomically, socially, so many different things that can really factor into how you might interpret certain labs and whether that might really key you into a certain diagnosis or not. And so I would say I was always taught and really have felt in my clinical career, right, which again is brief, but not that brief, say about 13 years, almost 14 years. So, story, if you just ask the patient the right questions, if they kind of tell you the right details, then probably 70, 80% of the time you should have the diagnosis right there. And then, a lot of other cases are really, yes, perhaps complex, and you still want to do your due diligence because there are lots of other things that sometimes can explain that. So that's not an excuse to just say that and sort of walk away. But I still think you should work people up and do the traditional kind of, rule out everything else. But anyway, clinical picture is really such an important piece, right, of how you interpret an X-ray, a CT scan, labs, any other data that you're getting in medicine, right? It ultimately still, I would say we're still at a place where that is probably the most important thing. And why, right? I think science is still actually pointing us in this direction. I referred to epigenetics, right? That complex interactions between our genes and environment really leads to unique biology in all of our bodies, and unique brain, let's say, just at baseline, right? So if you have a unique brain, then of course you're going to have all this unique stuff happen in everybody's bodies. Your brain is literally changed by almost every experience you have, right? And then all your genes interact with the environment in complex ways. So we literally are completely interconnected with our environment. Now we know this again as sort of from a scientific perspective, genetic perspective. So I have no reason to really then say that clinical story isn't one of the most important things, right? So that's not just me saying that maybe as a family doctor, but also as a physician scientist. So that's really my personal take on how you make a diagnosis, right? You really want to combine all of these things, have them sort of all point to one thing, and then you can really be sure about a diagnosis. If a few of those things are happening, but there's a few things that are unexplained, then we sort of have to, again, prove the presence or absence maybe of certain other factors, right? So that's the purpose of, folks in my clinic maybe that even have, are asymptomatic, casting a wide net and understanding how your lab work looks when you really do feel really healthy and good. Or, do you feel really good and there's maybe some lurking things that wouldn't have been discovered until something really devastating happened. That does happen in health too, and there are things we can find in that way. And so for a lot of reasons, right, labs are super important, but again, you want to have that combination of things, right? So they're not the end all be all either, right? So that's what I'm trying to say here is that
We had a conversation here earlier before you got in the car. And it had to do with, we are now as patients limited to such a short time to physicians anymore that we don't even really get a chance to have this clinical picture even half drawn.
sure.
And even as patients, sometimes we don't even know the right things to tell our doctor because not thinking that that one thing might be important
Sure.
in the overall picture,
Sure.
let alone that having the doctor have the time to ask us pointed questions that maybe we hadn't even thought about as
Right.
well.
I mean, again, you're getting to a probably bigger systemic issue in medicine that I do talk about a lot and we'll touch on here. But yes, I do think time is treatment. You'll find those exact words on my website, and that's not the treatment philosophy we have here at Desert River. So again,
We're not doing the doctors any favors, we're not doing the patients any favors.
Sure. So again, I can't speak to what anyone else is doing, right? If I believed in that, then I wouldn't necessarily be here independently. But I do believe in time as treatment. And I think, again, my wife does it in an amazing way too through insurance. So it is possible. But again, I think finding a quality primary care doctor is hard for a lot of complex reasons. I would say number one, maybe first and foremost, is that it's not incentivized from a medical system standpoint at all. And so, again, I would say now there's being some attention paid to, let's say, health and longevity, right? We have people that almost have to jump into a space like mine, right? Which is sort of outside the purview of some of the traditional care models to provide this kind of care. Which again, I would hope people in this community really understand that can be really affordable, right? And that there are people out there doing this at a lot more cost that maybe they could be doing it at, similar costs, maybe not, I don't know. But I've set up what I've set up. And so I feel very proud to do that, like I said at the beginning of the talk. So, but yes, is it a problem? Absolutely. So, snapshot.
This is
Yeah.
before.
Yeah.
She's new to you.
She is, yes.
So she doesn't know that she's in for a treat.
Sure.
Because he does.
I do.
Okay,
Yes.
he does take
I'm
time.
doing that. I've done my research.
Okay, yes, he takes time, he listens, he is analyzing. Well, I was in the other day and I come from the dentist and so I had to drink him out. Well, he was doing the analyzation without me knowing it. He was concerned that I was having a stroke. Until I told him.
No, I mean, not really, but I was half joking because the rest of you was working pretty well. So.
But I mean, that's what he does. So
That's why I'm here.
Well, thank you. So snapshot in time, what I mean by that is really just that, again, it's one static moment, right? So we have to have some data points over that timeline. Time is an important feature of our reality, let's say. And so spending that time to hear stories, spending that time over, a period of time to analyze the same data, the return to certain goals, right? So let's kind of tie that to that clinical picture story, right, of how we're going to build our health or maybe cure an illness. So time is, again, tied into this in a lot of different ways. So So I think I probably kind of already talked about everything on this slide. May have been a little redundant. But again, I think patient history, right, is really number one. And then I didn't necessarily talk about an exam. You know, and I do think this is sort of a dying art, maybe in medicine a little bit, right, that an exam can be really telling, whether this is a musculoskeletal exam to say, hey, you have this huge muscle spasm. Of course, this pain is, you know, due to this, or let's say a detailed psychiatric exam, which is maybe a skill that also, you know, shouldn't necessarily only be in the office of a psychiatrist. I would say family docs really should be trained to do that too, and all of us should, you know, kind of understand that mind is important in treatment. So again, but we want to combine all these data points, right, is really the point here. And then also, we just don't want to, we want to understand that sometimes there's a balance here, that if we get too many data points, this can also kind of throw maybe some confusion into the picture, especially, let's say, with radiologic data. This is very common and something, you know, everyone who kind of does a lot of radiology should know about, or really any patients that get a study. You know, if you get a very complex study, let's say like, well, nowadays, let me just even go to one of the more obvious ones. There's something called whole body MRI, which is, I don't know that any insurance covers this right now. It's a cash pay kind of thing for cancer screening, right? So it's a special technique, and it catches any kind of solid organ tumors, especially very good at catching that. And, but again, what's the downside? Why wouldn't everybody just go and get this done, right? Well, many of the solid little tumors in your body are probably benign, right? So now you're kind of obligated to, no, maybe no, you're not, but I would feel sort of that I would be obligated as your doctor to say, hey, we have to either biopsy this or rescan it, right? At the very least, rescan it at some intervals, right? So now you're committed to a few scans and maybe some anxiety over that period and some other things like that. So that's one example of how too much data does lead to maybe even direct harm. Let's say we go after a biopsy and then you have a major bleed, hematoma, infection, and, you know, again, so things can happen which were completely unnecessary for, you know, then what was just a benign, whatever, fatty lipoma or something like that. So, you know, again, some situations like this can occur, which, you know, you do not know on the front end. You know, everyone would feel like that's a reasonable decision. On the back end, you know, maybe you don't make that decision right, you know, a year ago or whatever after looking back. So it's hard to always know sometimes what that balance is, and we all have to have sort of our own comfort with some of risk tolerance, let's say, and you know, some sort of method, let's say, system of dealing with uncertainty, because a lot of life is uncertain. And so again, that gets maybe into a deeper discussion about just mental health and how to live and be healthy. Can we help you? Next door, sir. Yep. So again, that's really, again, what goes into a diagnosis, right? So I would say, again, a lot of weight on patient history. I don't want to try to break it up into certain sections, but I'd say definitely if the history is not matching the laboratory data, you want to trust the history. Let me say it that way. Right. And you want to maybe repeat the labs or ask more questions, or just stay curious is my personal recommendation and method, let's say. How is health assessed via labs, right? So again, biology is complex. So why is that true? That is true because, again, these labs are these big population statistics. There maybe, you know, these gene studies that we say, like, let's say the ApoE gene is tied to dementia, right? It has a 60 to, you know, 100% maybe increase in chance of dementia, especially in women. What's called an ApoE 4 gene. Okay, so if you have 2 copies, you can be very increased risks of dementia. But it's not, again, it's not, you're definitely going to get dementia. And so we have these genome-wide association studies. It's how we discovered this. So we take a huge pool of genes and say, well, what is the most common gene associated with this diagnosis? And so the randomization is that we took, 1 million random people in the population. And so the genes sort of randomize themselves, is what we say, just through, again, nature. So,
What test?
so the ApoE gene, I mean, that's like your genes. Yeah. So you can test that through the blood, basically. Yes. Common biological pathways, right? So I'm going to touch on that a little bit here. So these labs are informing us of how a complex biological pathway is occurring. And so understanding, again, that your sodium is high doesn't mean I need to eat less salt in my diet, right? Because the sodium is connected to, let's say, maybe water more than salt, or salt intake, right? It might be related to your fasting status. Was these labs held in a fasting status, or were there really, you came in super hydrated and your sodium is very high or low or whatever, right? So understanding that there's these biological pathways of which the data points are informing us, right? So just seeing a data point, seeing high or low, isn't necessarily always what it might mean at face value, with some of the there's just a lot of, I'd say, like pop science and sort of health advertisement out there, right, these days. And so this is what I'm maybe speaking to a little bit here right now, is just being weary of, how certain health products might affect certain labs, or, support your hormones, or again, et cetera, whatever those claims may be. It may, again, there are lots of supplements I use too in this office, and even, again, so, but again, just being informed about what that's actually telling you, what biological pathway it's sort of informing you about. And I've already touched on trends on time.
And is that, I know different tests, is it just a window in time, like you get a test and that says what's going on right now today, like you say, did I drink enough water? Did I have a salty meal the night before? But I guess there's some tests that are more like A1Cs.
Right. So, well,
covered like about a 3-month period, where some things might just give you a picture of today.
exactly. So, so again, that's where understanding the biology of which it's informing is so important, right? So that the number of an A1C is not comparable to the number of sodium to maybe the number of your triglycerides, right? And that those things inform us about, really are measured in completely different, A1C we will see is measurement of a cell membrane, of the red cell membrane, right? Whereas the sodium is a concentration of fluid, right? So we take the cells out of that vial of lab, right, to measure the sodium. So it has no cells, whereas the A1C needs to have all your red cells, right? So again, so how are these things measured? Understanding that whatever testosterone, let's say, that's on this slide, estradiol, et cetera, insulin, how did these things respond in response to mealtime, right? In response to your whatever relative, just a friend just died last night, and you got your scheduled for labs. So, what are you going to do? Or whatever, I went out to, the steakhouse and had a huge steak and margarita or whatever, which is maybe a real life story. So again, all these things inform what that lab work is going to look like, in the morning. And again, so it's sometimes even hard for a physician to understand all of that. So just giving, I just think it's important for patients to hear that, really, which is, I guess, why I'm saying it. So what are some commonly ordered labs? And again, I'll just say this is for me personally as a family physician and in a direct primary care. This is what I've developed sort of as my more comprehensive wellness panel. This is not every patient every single time, right? This is a personalized decision that we're making with every person in their care. So again, this is not to dictate anyone else's practice or to comment on what any other person gets as blood work. These are just some of the things that I use in my, let's say, toolbox of laboratory data, okay, to understand one's health. So
If you get a panel of this done, you're getting a really good picture.
yeah,
You're
right.
getting very comprehensive at that time anyway.
And I'll say, if we get pretty much everything on this slide here at my office, where I won't give an exact price, but let's say this definitely, let's say you probably won't break $200, okay, as a member here. So, so again, I'll kind of dive into some of the, I think this mostly is just kind of to look at a list, right? And we're going to go into some specifics here. So, and talk about what each one of these kind of acronyms means, although I'm not going to maybe say the word dihydro, DHEA, okay?
Oh,
So, so what's a CBC, complete blood count? What does that entail? I do have the consent of this person to show you their lab work, and it may or may not be mine. So that is, again, some of the data points that we'll see on someone's blood work. So white blood cells is what WBC means, right? So white blood cells help fight infection. Those, again, can be high for a variety of reasons: inflammation, healing, reasonable reasons, pain. You just, again, had a serious injury of some kind. You're fighting off an obvious infection, right? So it's not always a bad thing that your white count's elevated, or you're just on prednisone for some reason. So again, there's lots of reasons the white count can be high or low, but we want to understand that that is just a general count. We see units. Again, I didn't go into units here, but looking at the units on some of these labs is really important too, to understand that, again, comparing one to another is not always the same. Different laboratories that maybe have different units too. So sometimes you get labs at one doctor's office and you go to another doctor's office, and you need to be careful about how exactly that lab is measured and what units that lab might be. And so, or what exact methods, what exact scanners, what's their normative values, right? You'll see that they have certain different reference ranges even for certain labs. So again, I can't say I have, enough knowledge to comment real specifically on those differences. That is a really, really complex landscape. There's, again, probably over at least 30 to 50 well-known vendors running a variety of different labs that are on this list. So
reference interval mean norm? These are the norms?
So those are the population norms, right? So my understanding is that the lab will set it at, like, let's say 90 or 95 kind of percent. So, 2 to 2.5 standard deviations from the average, let's say, to be kind of specifics with some statistical terms, or basically just like most things. I should have had a bell curve on here somewhere, but yeah, so if you guys have ever heard of a bell curve, imagine kind of a upside down U-shaped curve. The tail ends of those, basically, if you plot everybody's numbers on a graph, it will kind of take that shape, and the tail ends will represent like the lower 5% and the upper 5%, right, of the values that you looked at. And most of the people will sort of be gathered in the middle. That's why it's the average, right? But some people who are not average will still be normal, and they'll either be very high or very low. And that's, again, why clinical story is so important. So, for example, people here at altitude do increase their hemoglobin and hematocrit. That is a natural adaptation to being in an environment with a little bit lower oxygen. The higher in elevation you are, the more this effect might be. So that's going right into those red blood cell markers, RBC. Hemoglobin is a protein that carries, oxygen in the blood. So this is measured by, let's say, light density through your red blood cells. So there's a laser that shoots through your blood, right, and then measures how much light it absorbs, right, at a certain wavelength, and then it's giving you a reading of a density of a certain protein on average in your red blood cell. So again, you get a number. We say it's normal, it's good, it's not, right? But it's a pretty, when you break it down that way, it is really kind of a amazing kind of thing that we've developed that technology and that we can so easily within a day just read out these things that are very accurately tell us this information, right? So when people, let's say they've had bleeding, right? I've been having a lot of bleeding from my gut. It looks like, whatever for weeks, right? And then they come out doing a hemoglobin and it's, 5, 6, 7. Sometimes that's a very dire situation, but let's say it's just even a mildly low 10, 11, right? Then it's like, oh no, that probably definitely was blood and et cetera. So these labs can be very accurate and telling and give us a real good idea of whether a patient's gonna need more urgent care or not. So that's how you can combine the two. So the following numbers with all the M's in the front, there are different kind of size and shape readings of the red blood cell. I'm not going to go into, again, details of that. That's not necessarily terribly important for the scope of this talk, right? But these, again, can inform about nutritional status. They do inform about the health of the bone marrow, right? So all of our cells are made in the bone marrow. So if you think about the CBC, what is the CBC testing the health of? Let's say the bone marrow, a little bit nutritionally, right? And there are some other chronic diseases that can affect some numbers here. For example, liver disease can present with, let's say, low platelets, right? Which are these blood clotting cells, which are the final cell line we'll talk about here in this lab. These form that sticky web and stop us from bleeding, right? Forming a clot and stopping bleeding is a complex process, but one particular cell is involved, and that's the platelet, right? So there are certain medicines that also work specifically on the platelet. For example, a well-known one is aspirin, right? So if you have a stent or if you have a high cardiac risk, right, or other reasons you might overly form blood clots, sometimes we put people on aspirin, right? And we call that sort of a, quote, blood thinner, right? But what it's actually doing is kind of mildly inhibiting this platelet here. So the following numbers at the end are sort of the breakdown of the immune cells. So you have different kinds of immune cells: neutrophil, lymphocyte, monocytes. That's what those things are: eosinophils, basophils. So those are the following numbers, right? A proportion of those white blood cells that are those immuno type of cells. So again, can give us some clues to what exactly is going on. Are there allergy tendencies, right? Or does this seem like a bacterial infection, viral infection? But again, not a perfect science there. So we say, yes, eosinophils are for parasites and allergies, and neutrophils are for bacteria, et cetera. But it's not always kind of a perfect science there. So yeah, but again, that's what a CBC is.
Have you seen the not established? I always wonder about some of those on the left, and it's like,
Let's see.
Most of them will tell you if you're high or low or if you're
Sure. Right. So that's a great example, right? So the white cell count, what is a normal breakdown of your white cell count is not known as a normal value, right? Because it very much depends on the clinical picture, right? So what's mostly normal is that most of the cells are, say 70 or 80% of them are neutrophils and lymphocytes. Breakdown, and then between that proportion, I don't think there's much real known about, oh, they should be this way or that way. So, so again, I'll just touch on that, right? So much of our biology and being is still unknown. So anyone who really thinks otherwise, I would really give a lot of pushback to. There's a ton of things we know. Again, I've used the word miracle, right? And I do think we have a ton of knowledge of a lot of different things about the body, and that continues to grow. However, there's still a lot of things that are a bit of a mystery and that we don't know. So I want to just kind of respect that too. What is a CMP, complete metabolic panel? And really, I think, more than the way that I use the word metabolism, this is a little bit more maybe about liver and kidney health. So that's how I would describe this lab. So glucose does tell you about metabolism, right? But and some of these other labs are tied to many things that kind of are what we call metabolism, which I would really refer more to like the system of insulin sensitivity and lipids, blood lipids, things like that. So anyway, so glucose is very tied to those factors and is controlled by the liver as well as the pancreas and a variety of other factors in the blood. So might be at the just too. So then going down from there, right? BUN, creatinine, GFR, all these numbers are much more all the way down to, let's say, calcium, right? Are really controlled by the kidney. And calcium, I'd say, actually is not so much controlled by it is controlled by the kidney, but also is controlled by your parathyroid gland. And so we have to evaluate, let's say, calcium in a different way than what's included, let's say, in even the list of labs I put up earlier. Protein downward really informs us about the liver. Okay, so looking at this, creatinine, right, is a byproduct of muscle breakdown. So people that are maybe a little more muscular might have a normal high creatinine. You know, again, I mentioned the relationship between sodium and electrolytes and hydration status has a lot more to do with that. Maybe some medications, other things like that, than really dietary sodium and other electrolyte intake. Now, this is in a normal, healthy human being. So if you have chronic kidney disease, or you have congestive heart failure, or you have some other complex kidney disease, or we just don't know because your kidney labs look crazy. So in those situations, right, that is not true, right? But if everything is sort of functioning and within the bounds of what we know is largely normal, then what I just said is largely true. So, you know, carbon dioxide, again, that's actually sort of dissolved bicarbonate. So that is, again, one of these other dissolved electrolytes in the blood. So kind of like baking soda almost might be like a similar kind of thing to that. Albumin, protein, globulin, these are different proteins that are generated by the liver. The liver does several vital things for the body. It generates proteins. It controls your blood sugar in a lot of ways. It moves around your cholesterol in a lot of unique ways, really controls that cholesterol. And then it also filters, right? We know that the liver is a big filter too. So this just tells us a snapshot of a few things that the liver is doing here, producing those proteins as well as filtering those toxins. So that's what that, and so alanine phosphatase, ALT, AST, these are enzymes within the liver, and they're actually in lots of other tissues, the kidney, the muscle, lots of other places, right? But if they are supposed to be within the cell, so if we're finding them in the blood, then we know that cells have incurred injury and released this enzyme, right? So now if we have, let's say, a severe muscle or kidney contusion, something like that, you will actually see elevation in these liver enzymes, quote unquote liver enzymes, even if there's absolutely no liver involvement, let's say. So again, we sometimes have these misnomers, right, for these labs, which are, again, data points of certain things. So you can see there's a unit, right? So again, this goes to the differences again with labs. This IU is a kind of international unit. So what is the way in which that's measured and standardized, you know? So grams per deciliter, millimoles per liter, right? So these are concentrations we're seeing there on the units. So anyway, kind of going back into the labs we were talking about, those quote unquote liver enzymes are not just enzymes in your liver. Keep in mind they're enzymes in many other tissues in your body. Okay. Cholesterol, so bloodstream cholesterol, remember, is a 10, maybe at max 10% of your body's total cholesterol. Every cell in your body generates cholesterol. Cholesterol is a fat molecule that gives the shape of your cell more fluidity and allows really complex biology to occur. It is the base of many of your important steroid hormones, like testosterone, estrogen, DHEA, cortisol. These things, you know, are all kind of based on cholesterol molecules. So when we talk about the lipid panel or bloodstream cholesterol, keep in mind that this is only a small fraction of your body's cholesterol. And it can be really telling, let's say, of a lot of different things. but only a couple of the numbers really are things that tell us about, let's say, your metabolic health specifically. Triglycerides and HDL are what I'm really going to zoom in on here a little bit, right? Which the triglycerides tell us sort of about insulin sensitivity and resistance. Insulin resistance is what then progresses to cause type 2 diabetes. I have a video on insulin resistance. That's one of my first videos I've done. So it's such an important topic, an epidemic here in America, and really worldwide it's becoming. So understanding where you fall on that spectrum, I would say, is vital to understanding the risk that you can really readily reverse in your life that is under your control. So that triglyceride number, I would say, is much more under people's control. Now, do people have genetically high triglycerides? 100% yes. There's many people that have sky-high triglycerides. If they, no matter what they do, they will always have that, unless they take some medicines that have been developed now. But that is, yes, something that happens. But in most people, what we'll talk about is that triglycerides are responsive specifically really to sort of overconsumption of carbohydrates. When we turn carbohydrates into fat to store them, which is what the body has to do, fat is long-term storage, carbohydrates are short-term storage, right? So our body, once we're overloaded with carbohydrates, turns that short-term storage into long-term storage, and bloodstream triglycerides rise as a marker of that, right? So the more that that process is happening, the more that we know that this overload of carbohydrate metabolism is happening, which is essentially the root cause of type 2 diabetes and then insulin resistance, kind of overloading the carbohydrate metabolism system, right? So, so that is how triglycerides are connected to a sort of deeper essence of health, okay? HDL is sort of in the inverse, right? So as our body is able to mobilize fat, a healthy metabolism is able to switch between fuels, right? When we need to burn fat, which is most of the time when we don't need quick bursts of energy, we should be able to burn fat. This is represented through a high mobilization of fat, and that's what HDL kind of represents, right? So that's cholesterol and fat moving around the body and being delivered back to the tissue of the liver to kind of process in that way. And so, again, that's not an exact picture of biology, but I'd say this is a good analogy, metaphor I'm making to how these numbers are sort of tied to health and how they move according to certain lifestyle factors. So as we become maybe more insulin sensitive, reduce those carbohydrates, increase our exercise, increase maybe some of our resistance training, eat some healthy fats in the diet, right? So nuts and seeds, omega-3 fatty acids, which many come from marine sources, but there are some plant and other algae sources as well. You know, these things can really help to modulate these numbers in positive directions. Right. And what we've seen, the interesting thing with the HDL is that you cannot really derive benefit by doing this through medicine. So niacin and some other interventions that raise HDL have never been shown to prevent heart attack. Right. And so, but people who have a naturally high HDL through these other methods do have lower risk of heart attack. So that's really what the data shows us.
There was a period of time, a number of years back, where I was training for a marathon. And I drove my doctor crazy because these numbers were off the chart every time he'd give me blood tests. He'd go, what the heck is going on here?
Sure, that's, yeah. And some interesting things can happen, right? Some people, let's say, is a ketogenic diet healthy, right? It's hard to say for everyone, right? If 10 people do it, 100 people do it, you'll see that their labs may look vastly different. And so, again, some may vastly improve and some may actually kind of, you know, in the traditional sense of these numbers may get worse, quote unquote. So that is sort of, again, complex interplay of nature and your biology and how someone's uniquely going to interact with their environment and what their habits. And the importance of blood work, I would say, again, is sort of demonstrated through that story. So, and clinical story. So ApoB, again, sort of total particle count of LDL. This is I go into this in my cardiovascular talk and some other talks, and there's lots of other, you know, information there about what ApoB is. But basically, in summary, I would say it is a particle count of the number of LDLs floating around in your bloodstream. And so we see that based on some population statistics there of heart disease, right, of where that should be. And so in my mind, this ApoB number, apolipoprotein B100, to be very specific, is to replace really those numbers above it, LDL-C and non-HDL cholesterol. I think in a lot of people's professional opinion, and in my kind of opinion, this number is a better number to have, and it is not very costly really to get this panel at all. Again, this is something that's, I think, essential for people to understand. A lot more people than me sort of saying that out there. So I'll kind of echo that as well. A1C, we'll show a little picture of an A1C, right? This is one of those cell membrane labs. So this is actually looking back to the life of your red blood cell. So does your red blood cell last 90 days, 100 days, 120 days, right? That is specific to maybe your current state of health, your genetics, right? Maybe those are two biggest factors, maybe some other toxins that, you know, if there's something causing blood loss, you know, so a few other factors there that might look fictitiously make this look higher or lower. But it's basically, as over that time, a certain amount of sugar is going to attach to the red blood cells, what we know about the biology of the red blood cell membrane and blood sugar. Okay. And so if sugar is very high, then we'll see much more sugar attached to that red blood cell. If sugar is very low over that time, then we won't see as much sugar attached to the red blood cell. So I mean, it makes a lot of intuitive sense, and it's a really cool thing that's been developed. You can actually check omega-3 fatty acids and I think maybe a few other factors this way, sort of some metabolites in our blood that you can check this way. So A1C is kind of through that method. Vitamin D, again, along with many other vitamins. So there's that A1C check there. You know, are basically concentrations. We want to understand that certain vitamins are concentrated in fat and certain vitamins are concentrated in water. You know, A, D, E, K are sort of the fat soluble vitamins that are sort of more dangerous to overdose on or easier because they stick around for a long period, don't come out of the body as readily. Those water soluble vitamins, a lot of our B vitamins and a lot of the other ones that you would see, electrolytes, things like that, minerals, we can flush out a little more readily. So not to say we should go overboard with anything, but just to be careful, especially with some of those that take longer to get out of our system.
Run that vitamin D by me again. It's not necessarily good.
Well, so what I'm saying is it's fat soluble. So if you overdose on it, it takes a while to come out of your system.
Okay, because somehow I think a physician told me to take more vitamin D.
If you're low in vitamin D, you should take vitamin D. What I'm saying is that if you go overboard, it takes longer to resolve that than if you go overboard with vitamin B. You can't really hurt yourself with vitamin D because you just pee out extra.
Right.
But if you're taking, let's say, there's people out there that by no prescription just go and take 50,000 units of vitamin D every day, 100,000 units of vitamin every day, right? And these are very, very high amounts, right? And so maybe you're taking a reasonable amount, right? But there are people doing other things that I'm trying to kind of educate and speak to, maybe not necessarily your case.
What's normal? Is this thing is normal?
As far as amount to take,
Yeah.
I would say titrate it to your vitamin D level, but 1 to 5,000 might be a good place to start for many people. But again, titrate it to your level. Talk to your doctor. So, right. So 1 to 5,000, I'd say is average for a lot of doses, and kind of on the lower end and probably safe. So even up to 10.
Comes with D, so now you got to count that with vitamin D that you are taking outside of it as well.
Sure.
And I always associate it with lack of sunshine.
Well, so that is how you produce vitamin D. So that is a note on vitamin D that yes, it is our version of photosynthesis. It is produced by sun on the skin. So that is the natural method of getting vitamin D. That has to be balanced with getting basically not sunburned to avoid the risk of skin cancer. And sunscreen does block the production of vitamin D. So while that is protective to skin cancer, it does also block the production of vitamin D. So it is a delicate balance. My general recommendation is about 10 to maybe up to 20 minutes a day of midday sun is generally safe to not increase your risk of skin cancer. And then put on protection, put on your hat, your sleeves, whatever, sunscreen, etc. after that 10 or 20 minutes, so again, that's a quick note on vitamin D there. So,
But it is, I guess, I mean, I know a lot of this stuff, but you kind of hit home with the fact that some are soluble and non-soluble. I always just say, well, I always thought, well, whatever your body doesn't need, you just pee out. But that's not necessarily
Right.
true. I mean, it can be, but it might take longer
exactly.
for things to happen. So you can kind of get oversaturated.
Exactly.
by not understanding.
Exactly. So we just want to be, again, thoughtful. If you have a physician that can help you, great. If you don't, then maybe you can also go to these there are more and more access to labs that, the patient dictates, right? So for those that are maybe watching online, not necessarily here, right? But I would say there are these kind of vendors that allow you to pick your own labs. And again, I really don't think this is a replacement for a doctor. What is the benefit? Let me just pause here, right? Sometimes I feel, and I think many other physicians might feel, that there's a bit of an attack on the expertise, right, of a doctor, that, there's these med spas and health and wellness places, right, and nurse practitioners that sort of call themselves doctors and PAs that call themselves doctor. And there are doctorate degrees for some of these things, right? But I think just being fair about your credentials, there is a difference in the education. The level of intricacy that I can tell you about this biology and how these labs are done, right, is not just knowledge I gained in med school, but knowledge that I then had to say, I have curiosity beyond what I learned in med school to really serve myself and my patients, right? So this is, again, decade or more of self-education on top of 4 years of med school, 3 years of residency, teaching for 6 years at a university program. So just understanding the experience and credentials of your, physician or provider, right? If they're not a physician, then, just understanding that there's great nurse practitioners out there. There's great physician assistants out there and other non-physicians, MD, DOs, international grads, wonderful ones that I've learned many things from. So I'm not here to, and again, bash any one group, right? But each person has a certain experience and credentials that they bring to the table, and that label doesn't always fully capture that, and what they put on their website doesn't always fully capture that. So just a caution to those out there looking for medical care. There is that degree does mean something. So okay. So again, my bias again. So guilty.
It's a good idea. But I've been seeing more ads on TV about, just call up and we have doctors on board that are going to ask you little questions, and then they're going to prescribe, Viagra or.
Right.
I
So
mean,
these places have, quote, medical directors, so they have to have a physician on file, MDDO, someone with licensed authority to prescribe or to dispense, medical devices, et cetera, on their board. What is that involvement? They could be in a different city. They could sometimes be in a different state. So again, just maybe trying to understand that relationship. Right. So is that someone that's there on site that actually comes to that facility, that maybe sees a patient or two or reviews some charts, right? Or maybe just signs some papers that they never even read. So yeah. So unfortunately that does happen, and I'm not the first one to talk about this. In fact, John Oliver had a whole bit on kind of med spas that sort of went into a lot of this. So that's on mainstream media, even in some ways. So, and lots of local news reports on that, that have kind of investigated local stories, right, of just horrific things happening to people, because of sort of people with really no licenses doing things that should be considered, medical procedures. So again, sort of off topic, thing can be on labs, but pertinent, I would say, to safety and health. So,
It pays to have somebody who knows you,
right. So,
and I think that's.
Stay away from the hydration station.
Yeah.
and understands biology, right? So not just that, right? So we can find personable people, right? But then we can find knowledgeable people, but combining the two is sometimes hard. So I will admit that. So, but you at least want someone that's, if you're going to get a complex medical intervention, you want someone that understands that there's complex biology that they're tinkering with, and how to help you when that goes wrong, right? How to recognize when that goes wrong. Are they using technique that is safe, right? So those are the kinds of things. So pathology, this is kind of what cells look like. I just want to give some people some visuals, examples, right? So we take some tissue, we put it on a slide, right? It may look a certain way. So the physical or the visual appearance actually is a big deal. So cancer appears a certain way. It's a rapidly mutating and dividing cell, and it doesn't look like the tissue around it, right, under a microscope, or even physically, right? Hey, there's something on my skin. I think it's skin cancer. That's how you diagnose skin cancer. You look at it, right? How do you diagnose colon cancer? You look at it with a camera, okay? And then we take it and we look at it under a microscope, right? There again, some special stains we do. We send off certain antibodies. We send off certain genetic tests. And these have led to very sophisticated, even specific tailored treatments now. Things like RT, which is you're programming your cell to fight off a specific form of cancer. So again, all sorts of different sophisticated things that we've created from the knowledge of this biology, right? But for those out there that think, again, there's a lot that I said that's not known, but there is a lot that is known, right? And these things do work. Shout out to my mother-in-law, who sometimes comes to these talks virtually, who had CAR-T and is really doing really well. So again, but these things work, and even people I personally know may be dead, without some of these technologies. So really, really cool things we have at our fingertips under the right kind of guidelines, let's say, and guidance and situations. Cultures, PCRs, so what do kind of those look like, right? We take something from a tissue. So one thing I'll kind of touch on here. So I mentioned that you can have genetic amplification of PCR, COVID. You guys ever heard of that? So when we were in the height of the pandemic, there were all these stories, right, of folks that would test positive for weeks on end that were, clinically better. What do we do about this? What does this mean, right? So this highlighted some of the problems, let's say, with PCR and genetic amplification, right? So that we can detect the gene, we can detect spike protein, we can detect whatever, but does that mean the virus is replicating? Does that mean you're infectious? Does that mean you have an infection? That is not always 100% clear. So we'd like to think that the presence of a bacteria means you have an infection. That is not what an infection is, right? There are bacteria all over our skin. There are fungi, viruses, et cetera, in our nose and our skin, different environment in our mouth that changes as we go through our gut, different environment of our stomach that then changes as we get into the colon. So then we say we have a microbiome. Well, we do. We have probably, dozens of microbiomes, actually. So we refer to that word and maybe talk only about the colon bacteria, right? But just to realize that that is true of many of the spaces on our bodies, and that we have a complex relationship with these little microbes.
Belly button is a world unto itself.
There we go. So it's gross and awesome. So there's so then infection, right, is a disequilibrium. So then things are falling out of balance, right? So or it is sometimes the introduction of a totally foreign agent. So I mean, that does happen, and there are some things that we know that just shouldn't really be in your body. Okay, but even some certain types of, let's say, like parasites, there's a community out there that like self even infects with certain types of parasites, which they say will actually help with certain allergic symptoms, right? We know that eosinophils in theory, evolutionary theory, the eosinophils were meant to fight off parasites. And so when our body doesn't have parasites to fight off, it fights off ourselves, is one sort of theory of allergies and how eosinophils kind of are involved. And so then there was a community that did do some experimentation with this. And again, I'm not recommending this medically. I'm just giving information that does feel that many people benefited to have less allergies. You get the trade-off of some mild anemia and some others. Not like you're totally asymptomatic from this either. So can be a risky intervention. But again, just getting a microbiome readout, a culture, a PCR, right? This can be really great information, but I hope I've relayed how this can actually, again, not fully give the whole picture. And this is why microbiome research is so difficult and has taken so long, and why we don't have, oh, this probiotic fixes that and this probiotic fixes that, right? Why it's sometimes they don't do anything, right? Because when we stop taking them, all those bacteria go away. So again, it's just an illustration of how complex this is and how these labs tell us some things, but not everything.
Can I ask a question about the genetic amplification? I'm not grasping that term.
So basically, do you know what a gene is a little bit? Okay, so DNA is kind of a double-stranded, kind of thing, and then it has basically 4 codes, right? Those codes in a row kind of make a unique gene. And mRNA is 1 strand. So different amplification techniques use these basically biologic enzymes we found that can, so you code, literally like you'll code and say, okay, we know that COVID has this sequence of genes. So we're going to, on a computer, code a little enzyme to have this tag. And the only thing it's going to amplify or replicate is that exact match. And so what we'll see is that when we run this process, we'll get more and more copies of this gene, right? And so that's where the copies kind of come in, right? So if we run so many cycles, then we would expect that there are so many copies that come out. So that's what polymerase chain reaction, right? So this was discovered because of actually a little archaebacterium, I believe, on the vents in ocean floors. That was the first kind of place this enzyme was discovered, and the PCR reaction was won a Nobel Prize for, right? But the scientist that found this was it was in a I believe on a one of those thermal vents deep under the ocean.
Just look a little closer.
Right. I mean, then they may be some of the most ancient biology known to Earth, right? Because some of the nutrients and things that probably led to life probably came out of these thermal vents. So anyway, so really interesting, and kind of the deeper, why would I say this? So many things are interconnected too. I'll kind of go on another tangent if you allow. The more I learn about biology and science and the world, I find that things are really deeply connected on this earth. That is what I think most science really leads to tell us. And so, again, I think that's just at least my conclusion that I've drawn in my own readings and research, and formal and informal education both have really reiterated that things are really connected to one another on this planet, and that the evolutionary process is kind of the way that these ancient bacteria work is connected to us in some way, right? And it is now, at least in this one way, through these amazing PCR reactions, right, connected directly to humans now, these really ancient bacteria. So just again, a cool personal story, a take on that, let's say.
But it really comes home in that we are all connected, and when you disrupt ecosystems, a lot of times you have no idea what you're destroying.
Right.
until it's too late. So
Absolutely. I'd echo that.
we
So.
have to be proactive in protecting.
Sure, sure. Again, I think we are, the more we see ourselves separate from nature, I believe that's damaging to all of us. So, so again, my opinion there. So,
Your poor caretakers.
uh,
Our home.
hormones, really, really complex topic. We could do, again, probably several talks on this, just one. Major concept I'm getting at here with these diagrams is what's called a negative feedback loop, right? If you see there's sort of a theme going on here that, the brain has a signal to an organ, the hypothalamus and pituitary signal to our testes or ovaries, then to make a certain end product, which we might measure, right? Testosterone, estradiol, progesterone, growth factor, etc., cortisol, so many things that go in this category. Thyroid hormone over here, pregnancy hormone, HCG, digestive enzymes, so inflammatory compounds. So many things go back into this loop and then, hit something in the brain or maybe elsewhere peripherally, a gland that might control. And then usually that negative feedback loop means that at a certain threshold level, it's going to shut down production of that gland naturally, right? So if I give you a ton of testosterone through a pellet or a cream or injection or whatever, nasal spray, etc., then that is going to affect your natural tissues in a very expected way. That's just biology, right? So this is not meaning you should not do that, but this is, again, well-known sort of biology, at least in a broad sense. We know that these things are going to happen. So this is how these things are related to these other hormones, right? And why would I have to measure LH, FSH with your testosterone, with maybe a DHEA, with a cortisol, with, thyroid hormone and the inflammatory markers all at once, right? Because this is what is happening, right? So people want to get sort of maybe just, quote, basic labs. And if everything looks great, then maybe I can just confidently say that, it's okay. But when things maybe aren't quite right, that we have to understand what it is we're measuring here in the body, right? And how intricate these systems are. And I've found that the medical necessity bar for some of these programs out there, these other payers of healthcare, are really a high bar for people to reach, for physicians to have to reach to get people's lab work done, let's say, in an intricate way, right? Whereas I can order in our model, a direct pay model, right, some of this blood work for, again, just a fraction of the cost of even one insurance rejection, or even these, let's say, other vendors out there, these self-pay vendors. I would say being a member at a direct primary care under the care of a physician, you can actually still save a ton, and then have a person to talk to, about your blood work. There's these like Inside Tracker and Rupa Health and other functional labs out there too, which again I'm a big fan of and don't necessarily recommend against. But let's just recognize that that's different than having maybe a doctor too. So anyway, so there's a little bit about hormones and how super important, right? But also really complicated. And the other biggest thing to say here, right, is that not everyone's numbers, right? Your numbers are not going to make everyone else feel good, right? Even, or your numbers that feel bad, right, might not always be numbers that other people feel bad at, right? So don't compare your numbers to someone else's numbers necessarily. There's age-related variations. There's actually daytime variations of many of these hormones. They change over a 24-hour period, even in a very predictable way. They should, at least. And so, again, we have to keep all of that in account. For women, you might remember something called your cycle, right, which describes, again, also another hormonal, right, fluctuation that is just more readily obvious, let's say. and has some physical signs and maybe even some cognitive signs and symptoms, right? So how much this is tied into your biology is maybe more evident to some of our, some of the smarter folks in our genetic pool. So vitamins. So again, how are vitamins tied to health? That's kind of the point of this slide, right? And I don't have all the vitamins here. Go ahead.
I don't know if this is going to be part of your talk, but before you get too far along, DNA, you haven't touched upon how I see on TV all the time where science is discovering how they can correct this DNA or that DNA for a particular illness or whatever. But it's still seemingly like quite a bit in the future before they can do much with working with the DNA. How do you feel about that?
So hopefully I've touched a little bit on kind of how genetics is very complicated, right? That nature changes our DNA in complicated ways.
So as far as medical, you're not.
Well, so just give me 1 second here. So there are many genetic conditions that are directly related to, let's say, one particular gene that creates one particular protein, hemophilia, sickle cell disease, even certain cancers, again, there's a variety of different diseases that are linked to very specific genes.
Right.
Those are very good targets for what you're talking about, sort of gene editing technology, which is something that is probably in the works, right? So we do know enough about this. CRISPR is one of these technologies where we can very specifically cut in and out genes from parts of our cells. And so I would say, yes, that is an up-and-coming technology. Is that going to lead to treatments of obesity, schizophrenia, depression? I think that's probably highly unlikely and complex, at least in my lifetime. And hopefully I'm wrong, but because again, AI and computer learning and stuff may just change our world here. But right now, how things are going, right? That's such a complex interplay of things, and depends so much on how you live your life and the sort of internal stories and things of that nature, and consciousness, right? Which I haven't even talked about here, right? If you believe in something like that, or spirit, then again, so I would say for some very specific diseases, that is something that is on the, I'd say precipice of becoming a reality. But it's not realistic for, let's say, the things that as a primary care doctor I should be doing for you, preventing heart disease, preventing dementia, well, those are very, specific and, let's say, not super rare, but very, I don't know the right word, esoteric. I mean, they're just like really specific siloed diseases, right? So you can have hemophilia and have type 2 diabetes, right? One is totally not, you're born into it. One is totally because of the way you lived in your environment. Perhaps that can happen, let's say, for sure, very easily. So that's what I'm saying, right? So the gene editing would be good for the hemophilia in the same person, right? But might not fix their diabetes. So that's what I'm trying to say. So.
I think we're going to have to go.
Okay, no problem.
Thank you.
Thank you
Yep,
so much.
absolutely. I'll try to wrap up soon here. So vitamins basically are kind of involved in a number of different metabolic processes largely. So these are, again, this slide I know is really busy, but so that's supposed to be a mitochondria there in the green. And your mitochondria is the powerhouse of the cell. Right? You can see that many people talk about B vitamins are for, quote, energy. So this is why, right? Because B vitamins are used in enzymatic chemical reactions to create cellular energy in your mitochondria. Okay. Does that mean that if you take B vitamins, your energy will get better? No. Not necessarily. Let me say not as a blanket, yes. So that means that if these processes are not happening correctly because of your B vitamins, then sure, right, sure, absolutely. Then yes, that will help you, absolutely, right? But that is not a definite, your B12 is 2,000 right in your blood and you take another B12 injection. Is that really going to help you? No, absolutely not. Not at least under any biology that we're really aware of, okay? Again, under certain bounds, right? There are certain things we can measure, like this homocysteine, your actual B12 level, the folate level, right? The level of these vitamins, we can check those things. I'm not saying don't investigate them. I'm just saying, again, healthcare marketing out there, wellness marketing out there, that may make people think something different than what these labs and vitamins may actually do or mean. So D is involved in calcium, as well as bone health, as well as the immune system, right? And is almost even considered a hormone more than a vitamin in some ways. And so, again, sort of not listed here and has some complex mechanisms of action that I couldn't really list here. Absolutely. C is sort of more of an antioxidant. So that's one category I didn't list here, right? There are certain vitamins like C and E that are more antioxidants, which mean they bind with sort of reactive chemicals in our blood, which could otherwise damage DNA or damage cell walls or damage tissues. So people say it's for immune health, right? Yes and no. When you have a rip-roaring infection, your immune system's very flared up, you create a lot of these free radicals, having some extra vitamin C may help, right? And that's why we see these mixed results with things like vitamin C and maybe some of these other, antioxidant kind of interventions.
Therapy,
Sure.
and I am convinced that, that emergency, that's what kept me alive. I am not kidding. Every time I took that, I just felt,
I mean, again,
I could almost feel it.
right. And people, will ask me, well, what do you think about pharmaceuticals? Or, it's like vitamin C taken at really high doses can act like a pharmaceutical in some ways, or, right. So it's, we want to know what the interaction is with this intervention with our biology, right? Thinking about it in a more broad sense, if I'm putting something external into my body, how does that interact with my biological processes, I think is what I really advocate for. I've heard kind of some of my mentors like Peter Attia kind of mention a similar attitude, right? Exogenous compounds are some of the words he might use. So again, not just me, but a lot of people kind of have this little more global view of how vitamins or food or activity can be medicine. We're going to hopefully go on a little walk here and get some medicine with sunshine and movement, which is not what this talks about, but it is good medicine. So that's a little bit on vitamins. Again, so many things we could talk about. Sorry, I can't be comprehensive. I'm doing an hour and a half almost already. So, but trying to at least give people something to start with, let's say.
But then I'm the opposite of you. I take insulin. So it always flashes up on the screen, don't take more than 500 units of vitamin C or it's going to affect me in a different way than it did you. So
Sure.
we're all different.
Right. So again,
Be aware.
not living in those absolutes, right? Great. I would say one great point here to put in that wrap-up category. So labs are data. We want to have that whole story, right? What are your other medicines? What are your other conditions? That's what dictates then how we might even respond to these labs. It's okay that, whatever, this lab's a little bit out of range because XYZ is happening. And we know that's temporary and it will go away. Or again, no, that's really alarming. That's brand new. Your lab has always been here and now it's up here. That's a different story, right? So, I shared on things like insulin resistance, cardiovascular disease, two of the major killers here on our earth. Labs can sometimes tell you many decades before you have a heart attack, right? Before you get that A1C of 12, because you feel like crap and you go to to the ER and your blood sugar is 400. So there are better ways to get this diagnosed. Just a plug for primary care out there and looking at that lab data. There are things that you may not feel that labs can show also, right? So yes, not perfect, but still also can be very telling. So that's what I'll kind of say in wrap up. And they're also very complex, right? So science is amazing. Science is wonderful. We have all sorts of cool technologies, but they're not the end all be all. And we want to make sure everything fits.
Listen to your body.
Good talk.
Thank you guys.
Yeah, thank you.